I'm Edwin Newman, and the program you are about to hear is an unrehearsed discussion by three investigators who have had a special interest in crisis and the management of crisis, particularly the crisis dying patients and their families go through. In bringing you this program, Abbott Laboratories hopes you will find that some of the ways our discussants suggest dealing with dying patients and with the grief of their families may be useful to you in your own clinical practice. Before our discussants begin, however, and for those of you who may be unfamiliar with the somewhat special meanings the terms crisis and crisis intervention have for our participants, it may be helpful for me to say just a word or two about them. As used here, crisis intervention is a technique many psychiatrists employ in both private practice and institutional settings in treating certain types of patients quickly on an emergency or near-emergency basis. The technique differs from traditional psychotherapy in a number of ways. First of all, unlike traditional psychotherapy, which usually lasts anywhere from 6 months to 2 years, crisis intervention covers a relatively short time span. The usual limit is about 6 weeks or 6 visits. Second, in crisis intervention, the therapist tends to be more directive and active than he usually is with a patient in conventional psychotherapy. Third, the goals of crisis intervention are different from those of traditional therapy. In traditional psychotherapy, the object is to get the individual to open up, to explore and face emotions and feelings. Instead of exploring emotions, crisis intervention tries to solve immediate problems. The therapist tries to help the person in trouble identify what the trouble is. He tries to help the person find a practical answer to that trouble. He tries to help him find ways of coping with his problem. And after that, his crisis intervention is ended. The therapist and the patient say goodbye. Psychiatrists have actually been doing this kind of therapy for a long time. They've always had patients who have come to them with short-term situational problems they needed help with, and, after the help was given, the patient would have no further relationship with the physician. In this sense, such patients are like those who appear in normal medical practice with an acute illness, such as an infection, in which the cause can usually be quickly determined and the infection brought under control with a specific antibiotic and appropriate medical management. Once the patient is relieved of his illness, he may never reappear for more general medical evaluation and continuing preventive care. Crisis intervention, with its limited goals, short treatment time, and relatively active approach on the part of the therapist, is a psychiatric analog of this kind of medical situation. One other important background factor is the nature of crisis as the psychiatric specialist sees it. As described by Gerald Kaplan, one of the major contributors to crisis theory and practice, the individual in crisis is in a state of psychological disequilibrium and is particularly susceptible at this time to outside influence. The crisis state therefore represents a time of maximal opportunity for improvement on the one hand, and of maximal risk of less adequate functioning on the other. Some investigators have distinguished 3 kinds of crisis: full-blown psychiatric emergencies, accidental crisis, and developmental crisis. This program focuses on the second of these, the accidental crisis, in which the precipitating event is an external happening, such as a death in the family, a myocardial infarction, or some other life-threatening disorder. Our participants are concerned with the ways of helping individuals to cope with their emotional state in this situation. Our participants do not share identical points of view, as you may infer from hearing this exchange on what we just referred to, the nature of crisis. I'll introduce the speakers after the exchange.
Just to get a better idea of what we have in mind by the notion of crisis, suppose someone had $10,000, $20,000 in the bank failed, and he's now absolutely destitute, but he doesn't know it. Is he in a financial crisis?
No. Well, financial, I don't know. But he doesn't know it. As far as I'm concerned, he's not in a crisis.
Right. And he may be the kind of individual who doesn't care that much about money.
I would say that maybe we ought not call it crisis, but that a severe disruption in someone's emotional or social organization is a basis for concern for attempt at help.
But I mean, what we're saying is that your disruption emotionally may not be mine, and mine may not be yours or the fellow that I'm
Okay.
looking at in the hospital bed.
And in your
But-
example of the $10,000, you said he does not know it.
That's right. That's
Therefore,
right.
there's no crisis, you said.
The voices you just heard were those of Dr. Robert Weiss, Dr. Peter Sifneos, and Dr. Thomas Hackett. Dr. Hackett, who is chief of the Psychiatric Consultation Service at the Massachusetts General Hospital, began working with patients with terminal illness in 1956.
In more recent years, I've been also working with cardiac patients, so this represents two situations where patients are faced with death. In one case, a kind of inevitable death. In the second case, in which they're presented with a strong possibility or the not so strong possibility of dying. So it's the threat of death more than the certainty of it.
A former head of the psychiatric clinic at Massachusetts General Hospital, Dr. Sifneos is now the Associate Director of Psychiatry at the Beth Israel Hospital in Boston.
I have trained at the Massachusetts General Hospital, and some of my ideas on crisis intervention were discussed with Eric Lindemann and Gerald Kaplan 20 years ago. I was very much interested in psychotherapy of short duration and psychosomatic problems, and now I'm at the Beth Israel Hospital doing research on those two subjects.
Dr. Weiss is a sociologist on the staff of Harvard Medical School in the Laboratory of Community Psychiatry.
I've been working for the past 10 years on problems of loss, the management of loss, as this appears in marital separation, in bereavement, and in the provision of services to those who are dealing with loss.
Dr. Hackett will begin the discussion.
I thought I would like very much to hear Peter's idea of crisis intervention, particularly since he's been on the ground floor of its development with Dr. Lindemann and Kaplan.
In my opinion, a crisis is an internalized state that can go for better or for worse. It is obviously unpleasant and motivates somebody to move one way or the other. And it is, I think, a term that was used in medicine when patients with pneumonia used to get high temperature, either turned for the better, they got well, or they died. So it has this kind of turning component. But the emphasis here is on an individual way of dealing with a problem. And the problem, in my opinion, can be external or internal. For instance, it can be a hazard that occurs in the environment.
Peter, what do you mean by a hazard?
For example, the death of a loved one would be the hazard, which then sets in motion within me a crisis. And I deal with this particular crisis by bereavement technique, which then eventually gets me over the bereavement and I function again. One also could define a hazard arising from the inside. For example, the fact that one is told that he has a terminal illness. That is something which is biologically starting within him, and he has to adjust to this particular problem.
Peter,
So,
can I interrupt just a moment? One of the things that we see in people, both in marital separation and in bereavement, is the difficulty in locating the source of the assault on their lives. And very often people will go into a kind of obsessive rumination over how did it happen, and actually be unable to get away from thinking about that, almost freezing on that issue. To the person in crisis, it sometimes doesn't look clearly as though this is something that happened from outside, and this other thing is something that happened from inside. Rather, that becomes a matter of really tremendous perplexity. How did it happen?
I would agree with that. What you're emphasizing is the response or the adaptation of the individual to that source, and therefore crisis intervention, which is our attempt to help an individual adjust to this particular crisis, learn to handle it until he overcomes it and continues functioning. So then crisis intervention is a therapeutic maneuver. And how one intervenes varies, of course, a great deal on the individual that one is seeing, and the assessment of the individual's character structure is of crucial importance.
But by and large, most of the problems having to do with the external crisis are handled by the primary physician, by the internist or the surgeon. And I think often there's a confusion about the whole issue of crises because the surgeons and the general medical people sometimes deny crisis. You'll find that the majority of people back in the 50s favored not telling a person that he had cancer, thus kind of avoiding the crisis. And I think maybe the thrust of some of the crisis intervention has reached over from psychiatry into medicine, because certainly now you do find more people who are honest with their patients, who are telling them the full facts.
Just on this point of telling patients open and closed awareness, We've had a number of women tell us after their husbands had died how difficult it was for them to maintain the pretense that their husbands were just, very ill, but the illness would eventually end. What it did was it made it impossible for them to share their own upset with their husbands. It interfered with the one relationship that was really critical to them at this really very difficult time.
The crisis in one person may create a crisis in another one. And as Tom was just talking about the surgeon is in a crisis if he doesn't know how to deal with a patient about his diagnosis.
How do you tell a person that he has a malignancy? Because if you do, it sort of poses a responsibility on you to follow through with something,
That's
like
right.
to cure them, which they couldn't do. And we're taught in medicine, by and large, to cure. All of our energies are directed toward that and not toward accepting the inevitable. The business of a conspiracy of silence has been spoken of in terms of the families of patients with a cancer. That is, the doctor always felt obliged to tell somebody in the family, and usually it was the next of kin, the closest person to him. And it always seemed to us a rather silly thing to expect that person, particularly a wife, if they'd had a good relationship, to maintain a silence, not to get back to that, to the patient, that he was terminal or about to be. And yet, it was practiced and probably will continue to be for some time until people realize that there are ways of imparting this news to people, that the individual who's been so victimized by the disease doesn't by any means break up or decompensate usually. It's a temporary response. Crisis, for the most part, resolves. I would say it's self-contained in most cases, but it can be aided in its resolution very definitely by some of the techniques that people have worked out.
Yeah. What we find is that very often there are indications that someone who was supposed not to know, in fact did know that he was terminal. Notes left behind. Final parting statements. Sometimes people are told very early in the course of a disease, and at that point can accept the information and act on it, and even to some extent plan with their wives for what will happen after they go. And then later start denying. I would think that what physicians should try to do is make it possible for people to choose whatever defensive arrangement works for them. So not to insist that a patient not be told, but rather make it possible for a patient to learn if he or she wants to learn.
That's the whole point, I think, of allowing oneself to be open to the patient.
Yeah.
Answering questions if they're put to you,
Yeah.
and not insisting upon they're following your tactic of
right.
silence or denial.
That's right. And of course, once a family learns that the husband or wife is terminal, it's family's under an enormous burden, and it's very necessary at that point that there be somebody they can turn to. And I think that often that's the point at which the physician feels, well, I've done my job. I've diagnosed what's going on, and I've presented a prognosis, and there's nothing more I can do, or maybe there is something more I can do, but it's strictly technical. And really there's an enormous need for support, advice, for access to someone that has some professional standing.
Now, the fact that a physician has diagnosed, let's say, a carcinoma is, in my opinion, the hazardous situation. The individual who has the carcinoma is in a crisis because he's presented with a difficult problem that he has to adjust to. And he responds one way or the other. The way by which one would intervene to help him or not to help him would be crisis intervention. Is that, we are in agreement with that?
That's right. I'd like you to continue on that, though, because I'd like it broken down, what happens, what we do, what
All right.
intervention consists
Because both of you did emphasize, Dr. Weiss emphasizes, for instance, support, and you sometimes emphasizes denial. I thought that the support is part of what one does, the denial is part of what the individual who's in the crisis does. And of course, each one of us does react to this in various ways. In my opinion, however, the intervention as such, or the crisis intervention, can be possibly also divided into two parts. Namely, the one that one helps the individual adjust, the individual doing most of the work, and the role of the therapist, if you like, is only to enhance an adaptive response. The other one is when the individual really does not have the capability of dealing with such a monumental crisis as a result of the hazard, and therefore requires massive support on our part.
Peter, do you put a limit on the number of times that the interventor or the psychiatrist sees the patient?
No. I would say that obviously a crisis intervention is a short period of time, but again I think that one is entitled to the luxury of being able to solve his own crisis in his own time. I feel very strongly against set numbers of times in which one is going to be seen. If we assume that the crisis is an internalized state of affairs that requires some adaptation, which can be positive or can be maladaptive. Now, this state of affairs in itself has to be identified, and this is usually an emotion or anxiety or depression or something of this kind.
And that's one of our first jobs, I think, in being called in as consultants. What really is it that's bothering the person? And then what next can be done to help them? There are certain standard intervention techniques, I suppose, that one can utilize, but I think the first task is to identify the source of the concern, the real trouble.
Right. I want to suggest that accompanying that might be a commitment to inform about the nature of whatever is the illness or the hazard and its likely course. So I'd want to suggest that in addition to a psychiatrist trying to learn from the patient what's bothering you, what's your particular imagery around what's happening, that the psychiatrist or intervener take some responsibility for saying, here's what's likely to happen next to you. Here's what's likely to happen next in your situation. Here's what you're going to be encountering. And maybe even here are some of the ways that other people have responded to it.
I don't basically disagree with Dr. Weiss, except that I would like to add that the individual understanding is, in my opinion, of crucial importance. And that although I may say that 99% of the patients may respond in this particular pattern, and this may be helpful, I still have to give that 1% the benefit of the doubt that this particular individual may respond in a different way, and it is my responsibility to understand him.
There's also something that I'd like to mention here about patients faced with the threat of death from heart disease. We've done a lot of work on them recently, and one of the peculiar findings that's emerged is that although many of them are aware of what's happening to them, that is, they're aware that they are having a heart attack, they don't fear death. Now, for some reason, you might call this denial. I'm not sure that I would. I've heard it so consistently, I would say it is denial in the best sense of that adaptive mechanism. But if you went into the room assuming that because somebody was having an MI that he was terribly frightened and began to smother him with reassurance, you might conceivably do more harm than good. And I think, again, this gets back to understanding the essence of the problem. I think it would behoove you to ask the heart victim if he's frightened before beginning to reassure him.
Yeah, I wasn't thinking of reassurance. I was thinking of telling people as factually as possible what's likely to happen next. So I have no experience with a heart attack situation, but I would think that in such a situation it would be useful to say, this is how long your distress is likely to last. This is what the course of the experience is likely to be. These are the symptoms you're likely to encounter. These are the procedures we're going to be using.
So in a sense, you're enhancing the anticipatory mechanisms of dealing with certain things that are likely to come up.
Absolutely. The capacity to cope.
I think that's a very, very good point. We do that all the time in heart attack victims. We do, for example, one of the things that comes up is the feeling of sadness, weakness, and depression that occurs upon going home. Now, the people, by and large, look forward to going home during their 3 weeks of hospitalization following an infarction. Yet when they get there, they're up and about really for the first time, and for the first time they're testing their damaged physiology, and they get tired very quickly. And they interpret this tiredness as a sign that the heart is failing. And it isn't at all. I think it's part of many things, but it certainly doesn't mean that the myocardium is failing. But we anticipate it. We tell them beforehand they're going to feel weak. This is normal, and their strength will slowly come back. And I think that this averts a good deal of depression.
May I ask you a question in reference to this so-called denial? You and I have discussed this in the past. The patient who has a coronary and is supposed to be frightened and keeps on telling you that he's not. Is it possible that he's not? is it possible that there are some individuals who do not respond emotionally in the same way as the rest of us do? And what is the crisis intervention then in some individual like that?
Yes, there's no question in my mind that there are individuals who can deny successfully the fear of the heart attack, fear of all aspects of it, not just the fear of death, but the fear that they'll be invalided by it, that the fear that it will stop their smoking or change their sexual life or change their life in all respects. And I think that we see a quite a sizable number of people who don't fear in the sense that we ourselves usually fear things. Yet at the same time, I think they're vulnerable to loss. In other words, I think that these people who don't fear personal disability or death show the same kind of grieving responses to the loss of a loved one that others do. But probably there'd be a subsection or subpopulation of them that might not show as much feeling.
We followed a sample of 52 widows for over a year, and we found in that group about 15 or so who didn't show extreme grief, who didn't show expectable grief on the death of their husbands. All but 2 of that sample showed intense grief later. It was fairly clear that what they were doing was maintaining their control and postponing. The 2 who at no point showed grief had been in what could be called empty shell marriages. There really had been very little relationship there with their husbands. I would feel on a probability basis that absence of the usual indicators could be taken as denial.
With our denial people, what we've now done, because we've never really trusted our clinical findings that explicitly, we interview people in the coronary care unit while they're hooked up to a polygraph, taking their GSR, galvanic skin responses, to see if, while they're telling us they aren't frightened, is their autonomic arousal such that we'd suspect fear. Yeah. And by God, we find that the deniers, for the most part, the good deniers, have an autonomic response that would be in keeping with their verbal statement.
That's interesting.
In not all of them, certainly, but what I'm saying is that in this subsection there would be some people who literally can deny fear, not only verbally, but also it would seem their nervous system goes along with it.
But then, Tom, why would you use the word denial?
I use denial because I can think of no better word. I don't like the word denial.
Well, can we suggest the possibility that these people indeed do not have the apparatus? That is, if they cannot fear, and if their autonomic nervous system does not show anything unusual, that they are somewhat different than the rest of us.
That's right. I think we can, yes, that's, yeah. Can you think of a word?
Yes, I have a very nice word, but that is not for this
that's
particular.
That's right, all right.
The word is alexithymic, fancy word. A for lack, lex is for word, and thymic for emotion. That is, these people have no words for emotion, and the implication is that they could deny as one out of many possibilities, but also that they might have been born with an absence of feeling in the same way as a person is born colorblind and cannot distinguish certain kinds of features in colors. Now, if I was born without an ability, let's say, to fear or to get angry, I can survive in this world very easily. I can be a kind of computer-like individual. I may not have very many friends, but I still can do very well compared to another person. And the reason why I come into all this is, and again, it may be indirectly relating to the study of crisis intervention, is that we may require different ways to deal with these particular individuals.
I think you're suggesting that the psychiatrists try to evaluate what's the degree of disruption that this has produced in the individual's life, and that different people with different emotional organizations may respond with different degrees of disruption to what appears to be the same assault. You know, as I think about this, and thinking now about men who've lost their wives, and I talked with a good many of them almost, within a week after the wife died, how different their response was as a group from the response of women. Women's routines weren't fundamentally disrupted by the loss of their husbands. Their lives were. Their emotional organization was. They were distraught, desperately so, by the loss of this fundamental figure from their lives. But they could go on doing what they'd done before. In fact, they could go back to the way things had been before their husbands became ill.
This is the end of the first side of your cassette. Our discussion continues on the other side. This is the second half of our discussion on dealing with the crisis resulting from death, the threat of death, or bereavement. Dr. Weiss continues the discussion.
Men, on the other hand, their lives were absolutely a shambles because they depended on their wives to run the home, to take care of the kids. And sometimes men were too overwhelmed by problems in reality to feel grief. It was like they had too much to do. They couldn't slow down to recognize what the emotional loss had been because they didn't have the time, they didn't have the freedom, the emotional, the energy.
And I would add, some of them possibly, they did not have the capacity.
Maybe, yeah.
It's interesting the way the shambles that a disease can make in a person's life. I was just thinking that, as I was listening to you talk, that a coronary, when it comes suddenly in a young person who's otherwise been healthy, they're stricken with chest pain, they get to the hospital, their pain is relieved, they're put in bed, they're surrounded by equipment and by people who are very anxiously taking care of them, and they don't seem sick, and they don't feel sick. It's as though the crisis, which is suddenly descended like an axe, they don't assimilate. And it takes them quite a long time to do that. An intervention in that circumstance almost first implies conveying to them a sense of what's happened to them without scaring them a great deal.
Yeah, there's a process in bereavement that I think parallels that exactly. The individual realizes that the spouse has died, maybe has witnessed the death, knows it's happened, grieves, cries, and yet doesn't believe it. He or she can't be dead. They're going to come back. Imagines that they're walking up the porch, hears their footsteps. Then gradually they're forced to accept the reality by arranging for a funeral, by witnessing the dead body, which is now different from the live person. But the acceptance of reality is never full at any particular time. It comes gradually, it comes over time.
So then both of you gentlemen have described that the hazard, which in this situation is the coronary attack or the death of the spouse, is followed by a period, is followed immediately by a shock, which appears to be paralyzing. And the individual may not be aware, really, of what is happening to him. So the crisis then may be delayed.
Yes.
And the crisis appears only when it sinks into that particular individual that they have had a heart attack, which requires certain different patterns of adjustment, or that their spouse is dead, which requires different patterns of adjustment.
Sometimes I get the feeling that people dose themselves with reality, decide how much of a dose of reality they can manage at any particular time, and shut off their acceptance of reality when it gets beyond that.
What happens to the individual who has been very dependent, let's say, on his wife? His wife died, there was this shock period and the disbelief, and then eventually the awareness that the wife was dead, at which point the person came, let's say, to see Dr. Weiss or any one of us. Now, at that time, he is faced with a new life situation to which he has to adjust. And he may, just for the sake of the argument, say, well, now, I was very dependent on my wife, but this is a unique opportunity for me to stand on my own 2 feet and see what I can do with myself. In that sense, I would argue that the hazard of the death and the crisis that follows turns for the better, that it provides me with an opportunity to adjust and possibly overcome a state of affairs that has existed, which was maladaptive. Sometimes a crisis may act as a positive stimulus for better adjustment, in the same way as it may act, of course, as a stimulus for a worse adjustment. So these two different, entirely different ways may be requiring the individual who is intervening now to try to help this particular person recognize whether the crisis is for the better or whether the crisis is for the worse.
I would be skeptical of a crisis intervener having in mind, as he works with someone who's in crisis, that this person can do well or do badly. I think that's burdensome. I think people already feel that they can manage things appropriately. Widows, for example, feel that there's a right way to be a widow. The right way is you express your grief, you cry it out, you get it out, and then you face life. You pick up the pieces. You go on courageously into the distant sunset, sorrowful perhaps, but strong. And widows can't do that. Nobody can do that. That's not the way grieving works. It's a long, drawn-out process with lots of regression. And it's laying a burden on somebody to say, You can do it better, or you can do it worse.
Well, I would have somewhat different emphasis there, but it is again what I alluded to before, the difference between somewhat sociology versus the individual approach, because you talk about the crisis as affecting, in a sense, all people more or less the same way. And in my opinion, it is of crucial importance to try to look at the individual
very interesting.
himself,
I think
who
you're right.
is going
I think
to,
you're right.
to adjust.
One of the things that we do in our interventions is to give them a very optimistic picture, at least as optimistic as the situation would warrant, and even then a little bit more. In other words, we encourage them to think that they're going to survive this and survive well, and point out, for example, that last week 12 people finished the marathon, the Boston Marathon, who'd had a heart attack within the last previous 3 or 4 years. I think it was the Ontario group who'd come down for that. And give them as many positive handholds as we can to get them through.
But don't you think that it is of crucial importance really for the person, before he tells the patient anything, is to know something about the patient?
You
You
always-
see,
sure.
if you take the history and you find out that indeed I wanted very desperately to depend on my wife, and as I give you more and more examples, this becomes of crucial importance. And I was looking forward, because the time that I had the flu 3 years ago, oh, it was wonderful, because at that time she had to go to work and I stayed at home, things like that. Therefore, you see, that would give you a clue as to what to tell me. And whether you're going to tell me about the marathon or not would depend on what kind of a person you think I am and what kinds of issues should I face. This is why I emphasize the individual understanding, which I made my point a little bit too many times, but I still want to emphasize that the evaluation of the person's past life, his character structure, and what is he likely to expect in the crisis is of crucial importance as to me as a crisis interventor, as to what am I going to say to him.
I think it would really set the pattern of your own anticipation, what you can expect from the patient. I think I might tell that person about the marathon, or not expecting him to get up and run at all, but to enhance his optimism for survival, so he can continue to be dependent upon his wife. But my own psychological set for his running would be very low. Again, though, would that be a crisis to him? If that gentleman had an MI and he had now a legitimate means for dependency, he wouldn't be apt to have a.
I agree with you,
anxiety
Tom.
spell.
This is not a crisis.
Hmm.
He's not asking for anything.
Well, I would think that if his life is disrupted, both emotional and social organization, that even though he may take it with a certain amount of gratification, that it deserves to be treated as a crisis. He's going to run into certain problems of crises. He's going to run into perplexity, the potential for panic as things happen which are very much surprising to him, which make him question himself, difficulties in developing a new direction for his life, changed identity. All of these are components of the crisis experience. I would say dismay, depression, upset. That's an important component of crisis, but it's not all there is to crisis. There are other things as well. And even people who seem to be taking something with a kind of benign indifference, a marvelous acceptance of this assault of reality, may in fact be in crisis because their lives are disrupted in other ways, and they're going to run into the same kinds of problems.
I'd like to hear you say more about that. I'm not sure I understand.
In other words, some aspects of crisis response are independent of the emotional response to the situation. There are reasons for thinking of something as a crisis, irrespective of how people feel about it.
So you see then here is a clear difference of opinion, because as you have just defined it, if I understand you correctly, Dr. Weiss, you bring in a crisis a sociological as well as an individual response.
Absolutely.
And I think possibly both Tom and I could not see this, because we view this as in my original definition, as being an individual response. And the environmental event, the hazard, or the person that, let's say, has the heart attack and doesn't view this as a problem because it's going to solve his life. He's responding to a hazard, but he's not in a crisis, in my opinion. While you see, would define him as being in a crisis, in your
You
opinion.
would.
Absolutely.
That we're clear on
Absolutely.
that, because I would agree with Peter. I don't see that as crisis.
Well, there are certain kinds of assaults that I think one can assume are emotionally disruptive, and in the absence of very strong evidence to the contrary, I would feel that this is a useful presumption. And one is a loss, a severe loss of an intimate, and I'd say another is a death sentence, being told that this is how long you have to live, and very likely not much more. I know more about the former situation. In the former situation, my sense is that no matter how someone says he's reacting, even appears to be reacting, there's good reason to suspect, simply on the basis of the nature of the assault, that there is emotional disorganization, disruption.
This is in the loss of someone, a loved one.
This is the loss of, the loss of an attachment figure, that person that makes you feel comfortable, at home in the world. When that person is there, you don't feel restless, lonely. You may not actually get on with that person. I mean, it's an odd fact that attachment is not necessarily correlated with liking or with an even relationship. But if this is the person that you depend on to make your world a secure place, a knowable place, a place where you have a place, then that loss is emotionally disorganizing in a very fundamental way.
But don't you make an assumption here? You see, you don't know whether that particular person whom you see is indeed. You assume that it is the case on the basis of your experience, which is of course true, as well as in the greatest number of individuals, which it is true. But you don't know that this particular individual is acting this way. Now this, for research purposes, of course, is one of the most interesting questions, because we see certain observations. We wish we knew what this person's personality was like before the event happened. And of course that we don't know.
No.
We see afterwards. But certainly there are some individuals who may not need another person and may go on through life handling things very well.
I think also confused in the concept of crisis, it seems to me, is the need for intervention. I think a lot of people can go through crises without having the need for someone to help them resolve it. And we don't see many of those people. It seems to me that oftentimes we inflict our sense of crisis on people around us, and that's wrong. I think more one must wait for them to come to you. In thinking, for example, in ways to help a patient accept the diagnosis of cancer, what practically speaking would one want to do? The first thing is to, having told the person, watch their response and see what they ask of from you, how they accept it. Does this mean to them, this particular malignancy, absolute fatality? Do they use the term cancer in its 1920 sense, that is, that it meant a gravestone? Are they able to see some of the advances modern technology has made against the disease? You educate them as much as you can, having told them the diagnosis. You answer whatever questions that they ask. You anticipate some of their questions. And you, I think, most of all, give them a sense that you will be there to help them through the illness. That's probably the most important aspect of intervention here, that you'll let them take the lead, but that you will be there to respond to whatever sense of urgency or need for help they have. And then the practical considerations are next set up, the priorities for treatment, what should be done. You take a practical interest and a hand in implementing the necessary steps that should be taken. But I think presence is one of the most important things, the presence of the person, the helping person, whether it's in the early stages of cancer or in the terminal stage. Death watch, for example, is a term used by many, many cultures, and it has to do with that very point, that a person who's dying isn't allowed to be alone, because I think being alone is one of the most fearsome, awesome sensations that the dying experience. Now, the same thing holds true to a certain extent with the heart patient. Having given them the diagnosis, you want to be sure over the next few days that they really do believe that they have a heart attack, because, again, they're often not having symptoms, and there isn't anything external that you can point to tell them that they have. You can show them an ECG, but they won't understand that. You can show them enzyme bumps, but they won't understand that. But you can give them certainly an intellectual understanding of what's happened to them, and then a pretty good idea of their prognosis, again, laced with as much optimism as you possibly can bring into it. I would, again, I think, mention marathoners and joggers and so forth, even though they might be very dependent people who want to be dependent upon their wives. And be there, again, this idea of presence, to answer whatever questions they have and to cope with whatever untoward emotions come up, and anticipate, I think, the presence of a depression when they go home, the discharge depression. So I think these are rather tangible things one can set up with in ways of intervening with heart patients.
May I ask both of you gentlemen a question as an example? For instance, in terms of death of a loved one or, let's say, terminal illness. Assuming that this is what has happened and the patient hears you very clearly, understands everything all about it, and then tells you, maybe not immediately, but after about a week, that this has been absolutely devastating to me, and therefore I do not choose to live, and I may consider the possibility of taking action. You now, what would be your responsibility? How would you accept this assessment of reality and this kind of challenge also?
If it's a case where he is bound to die, and if I can really agree with what he's saying, then I would be hard-pressed to keep life systems sustained. If there were some way to legally put an end to his suffering, then I'd be one of the first to take it, I think. Again, I don't think I'd make that decision alone. I certainly would want some colleagues' help on it. I may or may not want the help of a clergyman. I think that the family should be involved in it as well, although oddly enough the family certainly complicates the issue because first of all you're thrusting guilt on them and being a party to the decision, and secondly you'll never get an impartial view from them. So I'm at mixed mind having to do with family, but I think I'm much more on the side of letting termination occur than I am of prolonging life for the sake of prolonging life.
Isn't the end of life really the ultimate responsibility of each and every one of us?
But I think it's worth noting that we're making judgments regarding the rationality of the suicidal impulse, that we're not saying that somebody who is suicidal has the right to make that decision all by himself or herself. We're saying rather, in the one instance, it's rational. There's not much more life anyway. In the other instance, it's not rational, and we're not going to in any way collude with it, in any way. We're going to oppose it with all the force we can bring to the situation. We don't say what the patient wants is his or her privilege to have, because there are some times, many times, when a desire to die is a response to a situation and is transient.
But you see, I detect there a problem. Tom has emphasized clearly that the involvement of a lot of people with a dying person is a helpful thing. If, on the other hand, I recognize as a dying person that the involvement with other people is going to take away the right that I have of my assessment or the rational aspect of termination of my life, then that forces me into the lonely situation. And it is possible then, by being lonely, I may act in one way or other to end this life. So there is a kind of complicated, somewhat philosophical position here.
I couldn't stop him from doing it. I also think, though, that to get back to the bereaved, there are certain circumstances there when I would consider that a very rational and sound decision, particularly in the elderly. I suppose that, by and large, Providence takes over for us there because they so often do die in the wake of a beloved in their 70s and 80s. But I could easily see someone's taking the gas pipe if he'd lost a wife of 50 years and felt totally bereft and forlorn. I could think of no logical reason to keep him going, and I don't know how I'd intervene in that crisis, although I probably wouldn't be asked to.
Exactly. You see, this person would not be in a crisis.
That's right. He wouldn't be. He'd probably resolve it himself.
Yeah, it's a tough issue. I would imagine that one of the ways a psychiatrist might encounter it is in a request for sleeping pills. Very often after bereavement, people can't get to sleep at night. If they do sleep, they sleep fitfully. And that adds to the other sources of distress. And they do want medication and perhaps even need medication. But with suicidal ideation, it's very easy for someone to decide to save up pills. And sometimes it's not clear what someone has in mind when they come asking for barbiturates.
Excuse me, before giving anybody anything, I would like to know why is he asking me what he wants. If he's in a sense medicating himself, this is his decision that he has insomnia and he wants to take a pill, then why on earth is he seeing me? If he sees me, then he requests something of my knowledge, and therefore I would like to be involved in that particular decision, you see.
Just a question or two about it is enough to lift the lid off and have the person begin to open up and to establish a relationship with them, and then to worry less about the pills. But one first questions the reason, and then second uses medication that is as safe as one can get. We've talked about the cardiac patient, Bob. What kinds of positive handholds can one offer the grieving patient?
I think it's useful to tell people that grief lasts a long time, that it goes through phases, but that it's not something one can recover from immediately. that it's all right to cry, even though weeks and months have passed since the bereavement. And it's also all right not to cry. It's not necessary to cry it all out at first. That it's useful to keep busy. That's perhaps the best therapy. But it's not possible to do work in the very early days or weeks after bereavement because one's minds and feelings are occupied with dealing with the loss. As soon as possible, however, then it is desirable to pick up work, to do something, to keep active. It's important not to get panicked if one finds one's mind wandering back to the marriage or playing again and again the scenes of the first learning that death was imminent, or playing again and again in one's mind the scene in which one's told that one's spouse has died or in which one sees the death. These are normal grief symptoms. The inability to make one's mind work the way one wants to is itself a normal grief symptom and not anything to get panicked over. The same is true of inability to sleep, of loss of appetite, of restlessness. The same is true, too, of bitterness toward the world and toward people who haven't had this happen to them. And finally, I'd warn people that there's likely in time to be changes in relations with friends, which isn't anybody's fault. It's just that one's life changes its pattern. That you may keep 2 or 3 married couples as friends, but probably won't keep your membership in a social network.
I would agree with that. I think maybe I would add to that some physical feelings that often come in the grieving process. The sense of tiredness and lassitude, changes in sleeping habits, the tendency to either sleep too much in the daytime and too little at night, or to sleep all of the time or none of the time, loss of appetite, which is sometimes apt to be very acute, and then a host of somatic complaints, aches and pains and tiredness, headache and so forth. Those I think would add as being concomitants of grief as well, and to anticipate with the person that they feel that way.
I'm very much interested in that aspect. You may hear somebody who comes and talks to you about, for instance, how his hands shake all the time, or his muscles twitch, and that is what bothers him a great deal, or his headache is intolerable. He may use certain adjectives, but the person who complains of these things is not a so-called hypochondriac, or it's all in his head. These are actual physical symptoms that may be masking his depression and are expressed in this somatic way.
Well, let me say that there's a major difference between those whose bereavement was anticipated, where there was a long illness at the end of which someone died, and those who lost someone without any preparation at all through heart attack or through accident. The second is by far the more malign situation. There is a sense in those people that the world is absolutely untrustworthy. They don't know what hit them. They don't know from then on in their lives when something like that might happen again. But no matter how bereavement comes about, there's never a point at which the loss is forgotten, at which the loss is as though it never had been. It's a major event in the individual's biography. It always is something that made him or her the person he or she becomes.
Thank you, gentlemen. You've been listening to Drs. Thomas Hackett, Peter Sifneos, and Robert Weiss discussing crisis intervention with patients and families when coping with death or the threat of death or the problems of bereavement. This program is brought to you by Abbott Laboratories as a service to continuing education in medicine. Participation by our discussants today does not imply, nor is it meant to imply, endorsement of Abbott Laboratories products. We welcome your comments and suggestions and hope you have found this program helpful in your practice. This program has been produced for Abbott Laboratories by Medical Information Systems Division of Applied Concepts.